Hello everyone, my name is Megan and today we're going to be talking about neointimal hyperplasia. Okay, so let's start off with our patient presentation. So we have a 50-year-old woman that's presenting for a serial carotid exam. About 3 to 4 weeks ago she had an endarterectomy due to her critical stenosis in her distal right CCA, as you can see here and then the color as well. Since her surgery, she has complained of vertigo, intermittent syncope, and unilateral weakness, specifically on her left side. When prompted, she disclosed she had episodes of slurred speech and also confusion. Okay, so on the exam that we did today, we found in her distal right CCA this thickening of the intima, and then also on the color, you can really see it well here, where the color is actually displaced. And then when we did a Doppler in her prox ICA, we got elevated velocities that were indicative of a stenosis. So the radiologist dictated it and diagnosed it as neointimal hyperplasia. So what else could this have been diagnosed as? Well, it could have also been diagnosed as a late-stent thrombosis or just a thrombus in general. So the reason for that being is because thrombus veins are normally hypoechoic. They have a very spongy texture to them. However, the characteristic that sets them apart from neointimal hyperplasia is the fact that they're poorly attached to the wall and sometimes even found floating around in the vessel. This obviously does not occur with neointimal hyperplasia due to the fact that it is originating from the intima, and therefore you're not going to find it floating around in the vessel. Now with atherosclerosis, it has the same pathophysiology as neointimal hyperplasia, however the way that it comes across ultrasound is different. So it does contain a hyperplastic foci, and then here I briefly mentioned that it does have the pathological finding consistent with the activation of the smooth muscle cell proliferation, similar to that of neointimal hyperplasia. But the fact that it does have this foci and the fact that it does become more echogenic as it ages sets it apart from neointimal hyperplasia. So what exactly is neointimal hyperplasia? Well, it's also known as intimal hyperplasia, and it's basically a scar that's produced by your arteries and veins in response to a vessel injury or altered hemodynamics. So when I say vessel injury, I'm talking about the use of an angioplasty catheter, the use of an embolectomy catheter, endarterectomy, the creation of AV fistulas, coronary vein grafting, so on and so forth. So when you have this trauma, it eventually leads to platelet accumulation, endothelial regeneration, and proliferation of the smooth muscle cells. Basically, the cell number is increased because of proliferation and migration of vascular wall cells, predominantly smooth muscle cells. This ultimately results in a restenosis within 6 to 24 months following endarterectomies in our patient's case. So what is normal versus abnormal when it comes to intimal thickness? Well, first it's important to know your anatomy, because when we measure, we want to make sure that we're measuring the correct layer. So your intima is going to be your innermost layer here. Your media is your middle layer, and your adventitia is your outermost layer. It's more echogenic than the other two, and it actually has its own blood supply called the vasa vasorum. So when we measure, we want to make sure that we're just measuring the intima. Many studies have been done, and the upper limit of normal has been determined to be 0.9 millimeters. However, the intima media thickness increases with age, and it can vary between males and females. Males generally have a thicker intima. Because of these variables, it's been proposed to have a higher cutoff, especially as people grow in age. So what can we do to prevent / treat neointimal hyperplasia? Well, to prevent it, you can use pharmacotherapy. And then after you have your vessel trauma, so for our patient in this case study, her endarterectomy, you're going to be monitored for the next 2 years with ultrasound and Doppler. And then also to help prevent, but also to mainly treat it, you're going to be given aspirin or heparin, and this helps prevent thrombus formation and platelet activation. And then you're also going to be prescribed Pravucol, and Pravucol is basically an antioxidant that prevents neointimal hyperplasia by blocking the leukocyte recruitment into the subendothelial area of the vascular wall that's injured. And that is all for neointimal hyperplasia, and these are all the resources that I used. Thanks for watching.